This is a video about the literature research of the following topic: evaluation of the efficiency of osteopathy as an addition to the standard medical treatment against migraine. It is done by Julien Malané, supervised by David Levillon for the International Academy of Osteopathy. Migraine is a chronic primary headache without any neurological lesions. 15% of the population are affected, 19% of the women population and 11% of the male population. Onset happens on average between the age of 15 and 24 years of age, so quite young, with a peak frequency between 35 and 45 years of age. It is quite a high cost in treatment of 579 euros per patient per year with the standard treatment, which is by medication. Migraine is a clinical diagnosis. There is no imaging required. Two of the following pain criteria have to be true. It has to be either unilateral and or pulsatile and or of a moderate or high intensity. Furthermore, the patient has to have had at least 5 episodes or more of a duration between 4 and 72 hours. The pain in crisis is aggravated by activity. The patient is feeling nauseous, maybe even throwing up, and he will be sensitive to either light or sound, or both. Between episodes, the patient has a normal clinical exam with no abnormalities. The physiopathology is not fully known. What seems sure is that it is linked to an intracranial arterial vasodilation and a hypermobility of the blood vessels, which leads to leaking of plasma and a secretion of neuromediators serotonin and noradrenaline, which are at least in part responsible for the pain influx. The objective of this paper is to verify if osteopathy may be a useful addition to the gold standard treatment, which is by medication. This will be done by analyzing the frequency of episodes, by analyzing the intensity of pain, and also the quality of life of the patient. The PubMed database has been searched with the search terms osteopathy and migraine. This has given 227 hits, which have been manually screened, first by title, then by abstract, and if relevant later by full text. Inclusion criteria has been that the article had to be available in full text or abstract. Any type of study has been included, single-blinded, case reports, or other. Patients have been included of any age group, any sex, any ethnicity, or any religion. On the exclusion criteria, articles older than 1997 have been excluded. Articles treating other types of headaches have been included. And manipulations done by non-osteopaths have also been excluded. The literature we found used questionnaires to evaluate the pain of the patients, and mostly the 3 showed here have been used. It has been the headache impact test, the headache disability index, and the migraine disability assessment tests. All 3, as said, are subjective questionnaires where the patient rates his pain on frequency, intensity. To check for statistical significance, we used a software to compare odds ratio and relative risk to associate the strength of our results before after treatment and to measure their association. The first study we included was from Freud et al. From 2011. They used 42 patients, which they split equally into an intervention and control group. They used the MEDAS questionnaire, which all the patients did before the treatment, they did after treatment, and they did 6 months later as a follow-up. The patients receiving treatment got 5 osteopathy sessions every 2 weeks, meaning in total over 10 weeks, whereas the control group got no intervention at all. Their results show that there has been a decrease in pain of the treatment group. T1 are the measures before the treatment, and T2 are the measurements 6 months later. One can see that the number of days have been decreased, the number of days in pain. The disturbance the patients felt has been reduced, and the pain intensity has also been reduced. This could not be shown for the control group, which received no treatment. Cheritelli et al. From 2015. It's our biggest study we found. They used 105 patients, which they split equally into 3 groups. 35 people were in the intervention group, and they received 8 osteopathy sessions in addition to their normal treatment. The second group was a sham treatment group, also 35 people. They got their usual medication, and they got a non-manipulative sham treatment. And a control group which got nothing else except their usual treatment, which is medication. They evaluated their findings with a HIT6 questionnaire. They checked their medication usage, meaning a patient who is more often in pain uses more medication, and vice versa. They counted the days with a painful episode of a month, and they calculated the functional disability of the patients. They showed that the treatment group had the biggest decrease in all the criteria. The sham treatment group did also improve, which could be linked to a placebo effect, and the control group stayed unchanged. This is true for all the criteria. This is true for the medication usage. This is true for the days of migraine in a month, for their pain intensity, and for their functional disability. DiPolito et al. From 2017 used 11 patients without a control group. All patients got 4 osteopathy sessions over 8 weeks, and he used the headache impact test and the headache disability index before treatment and after treatment. They also found a decrease in pain intensity and pain frequency according to the questionnaires. Cecile Guy from 2014 is another graduation paper from an osteopathy student. She used 21 subjects, which she split into an intervention group of 13 and a placebo group of 8 subjects. The intervention group got 3 osteopathy sessions over 6 weeks, whereas the placebo group got a sham treatment. She evaluated her findings with the numbers of days in pain per month and with the pain intensity on a visual analog scale from 0 to 10. She found a decrease in symptoms, intracranial symptoms, eye symptoms, and range of mobility from the cervical spine. She did find also an improvement in the pain scale for the intervention group. Placebo group stayed unchanged. Intervention group decreased from a 5 of 10 to a 2 to 3.3 of 10. This paper did not differentiate between migraines with or without aura, so both of them are true for this paper. Tuchen et al. From 1997 used 4 subjects without a control group. They compared the frequency, the pain intensity, the duration, and the medication usage of the patients before intervention and 6 months later. And they found big reductions, especially in pain frequency and medication usage, but also on the visual analog scale from 0 to 10, and on the duration of the painful episodes. Anadottir et al. From 2013 used 20 subjects, which is split in Group A and Group B, and all patients received 6 craniosacral treatments. They crossed the subjects. They had a crossover between the two groups, and the difference was the timing of the treatment. Meaning Group A answered the questionnaires, got treatment, answered the questionnaires again, had a break, and answered it again 6 months later. Whereas Group B had a questionnaire, they waited, they had no treatment, they had a second questionnaire, and the treatment came only later. What is interesting to see is that Group A reacted better to treatment than Group B, supposing that an immediate treatment might be superior than a delayed treatment. Voigt et al., the first paper, they found a significant statistical link of osteopathy and the pain decrease, and they found a significant statistical link for the decrease of handicap. Always for the intervention group. No statistical significance could be proven for the control group, which received no treatment. Cheritelli et al., they found the biggest improvements for their intervention group, but also the placebo group found minor improvements, which could be linked to possible placebo effect because they got a sham treatment, and the control group had no big differences. Selinghi found a statistically significant decrease in episode frequency and pain intensity. Tuchin et al. Found small improvements after intervention on migraine frequency and pain intensity, again analyzed by the use of medication of the patient. Anadottir et al., who had a crossover between the two groups, the results that Group A treatment is superior than Group B, even though they received the same treatment but on a different timing, might imply that the timing of the treatment is important. This leads to the following inclusion. All the papers found a decrease in pain intensity, which they all mostly analyzed by checking the automedication of the patient. A patient in pain will use pain medication quicker than a patient who has less pain. They counted the painful days per month, which also have been decreased in all papers checking this criteria. They found a decrease in functional incapacity, and they found an increase in quality of life of the patients. High cost of treatment should push further research into this area, thanks to these promising results. The limitations of the studies were always quite similar. They could not be double-blinded because the therapist has to be non-blinded to be able to give the right treatment modality. Often sample sizes are small, raising the questions about this statistical link, if it could be applied to all the population. They have sometimes even changed therapists in the middle of the paper, or they did the paper they gave the treatment by several different osteopaths. Results stay subjective, even though the authors tried to objectify them with standard questionnaires, but it will always be the patient who reports about his pain. Results have been mostly analyzed in short term, all after 6 months, but it might be useful to have a long-term follow-up. And treatment modalities of the osteopathy sessions are, in most papers, unknown, meaning we do not know what the what the osteopath did as a treatment except for osteopathic manual therapy. This leads us to the following recommendations. We'd like to see further high quality studies with a control group who compare treatment against a non-medication group even. They should differentiate between different treatment interventions, meaning we had one paper who checked craniosacral therapy, while all the others did osteopathic manual therapy. They should include a treatment protocol to define their treatment modalities, which are used to explain their results. Thank you.